Yeah, it was 30 degrees this morning at about 9 o'clock here. So and it was 28 when I got up. So yeah, it was cold.
That's colder than we have it here in New York. That's cold.
Yeah, we're just having a little moment to make sure we remember that we're really not part of the South.
Yeah. Well, this weekend brings out getting the snow blowers ready, and yeah, it's quite an event.
Are we waiting on something, Matt, or are we ready to go?
I'm ready anytime. I can't tell who all's here and who all's not. I was just kind of hanging out. Looks like me and Steve are here, so.
Hi, hey, this is Scott Edmonds from United. I'm here.
I think I saw Gary Upchurch on.
Yeah, I'm here.
Tanya Klingelhofer from March Vision Care is here.
Well, I think, I don't know if James is on or not, but I think the four of us would be a quorum, so I guess we can get started. Does that sound good to everyone?
Yeah,
Yes, sir. James is connecting to audio, it says, so we should be good.
Okay, sounds good.
I think we are waiting on some more folks from, I can't tell who's joining either, but do we have Adrian?
Yep. Hi, hi, Ty. Yep, I'm here and Richie's here. So I think for March, we're ready to go.
Okay, thank you. I'm sorry, I couldn't see.
That's okay.
Well, if everyone's ready, let's get started. The first thing is, of course, approval of the last minutes. So let's go ahead and get that out of the way. I'll take a motion to approve those.
I make that motion to approve
Okay.
the August minutes.
Steve
Sounds
Compton,
good.
second.
Good. Any discussion on those guys? Was everybody pretty good with them?
Mhm.
If so, then all in favor of approving the minutes, say aye.
Aye.
Good. Minutes approved. Moving on, we'll just, as usual, go down the agenda list. That seems to be the easiest way to accomplish it. So we'll start off with March Vision. And I think, Steve, you had a couple of things you wanted to talk about, and I do too, but I'll let you go first.
Okay, this first one was actually brought up at our last meeting. That ophthalmology, or OMDs as we call them, I don't know what they call us, but anyway, bill directly to the managed care organization, and the ODs are having to bill the March Vision. And I'm not sure why there's a difference, and to me it's I don't know, it just doesn't pass the smell test. I don't know why we're not all doing the same thing. And I think March was going to get back with us after we brought it up, but we didn't really get an answer.
Yeah. Hi, this is Adrian. I remember the issue being brought up was on the parity laws, which of course we're well aware of, but yeah, and maybe Ann Ritchie can certainly speak to this as well, but you know, March is delegated to administer the routine vision benefits and services under the scope of an OD license. So certainly if an MD does vision care, or sorry, routine vision care, it would come to March Vision for payment, but any medical would continue to go to the plan for reimbursement. So otherwise, anything an OD will always come to March. So that's
Okay,
a
why?
little bit different.
Why does their medical go to the MCO when ours goes to March?
You know, I don't know, Anne, if you can add to that, but that's really just how, you know, it's delegated for reimbursement with the financial responsibility with the health plan. So,
hey, this is Scott Edmonds. Let me pipe in here because I've, since the beginning as an optometrist and the medical director. The difference is because the physicians ophthalmology do surgical procedures that are not outside our scope, hospital privileges. So they basically go through the plan's medical bias. So March doesn't have capacity for ASCs and for surgical facilities. So it's just the plan. It's the March. It's our desire to have all eye services. We desire to be a full eye care carve out, but the plan wants to keep the surgical ophthalmology piece segregated. So that's why there's a difference. But and we continue to push towards being a totally eye carve out that includes all surgery and by both ODs and MDs. But currently we're kind of limited by our contract with the plan.
Okay, still, when we do surgical procedures too, and that may lead into the next item on the agenda. That may be the problem with some co-management issues we've had.
Yeah, we do cover the surgical procedures that are within the scope of optometry. The one of the issues that I had is having been in optometry in a number of states is that we want to make sure that I don't know whether all the optometrists in Kentucky can do surgery, or you have separate certification for those that have passed credentialing, et cetera, for surgical procedures. I know in other states we have a separate group of the optometrists that have been worked ahead to go ahead and get laser privileges, for instance, and so we worked through that with them. But I'm not sure how we differentiate if an optometrist in Kentucky that bills us for a YAG laser, how do we know for sure that they're certified to do that? So we got to make sure that we're credentialing them separately, so the surgical ODs are credentialed and approved and paid for what they do, and the non-surgical ODs, if you have any there. I don't know whether everybody got grandfathered or whether you'd had different certification for surgical privileges for optometrists.
No one was grandfathered. My issue is we're being treated differently, and I've been around a while, and we fought too hard for parity that I'll just sink my teeth into it, and I'm not going to let it go.
and I'm sorry, Dr. Compton. So how do you? I'm not clear on treated differently. The reimbursement is the same, so it's just really a matter of sending the claims to one place versus the other. Certainly not the intent to treat differently, and I guess I'm not clear on what it is. So it's more of an administrative concern.
Yeah, and one of my
not a
questions
quality or anything. Okay.
to make sure that the reimbursement was the same. I had that question one other meeting.
Yeah,
and
right.
didn't really get a straight answer, so I got that answer. It's just we've been, if you've been around as long as I have, we've been slapped around a bunch, and we've fought too hard for equity.
Yeah,
and not letting it go. So when something doesn't pass the smell test or it looks fishy, I don't mind raising the red flag.
So Adrian, can I piggyback on that a little bit? And
Sure.
you guys can correct me if I'm wrong, but March Vision is really routine driven, right? And then the scope of the license we pay if it's outside of the ophthalmology piece goes to the health plan.
Right.
March Vision is more routine, but we do pay the same for what's covered in the scope of the license.
Right.
I'm sorry, this is the court reporter, and who is speaking, please?
I'm sorry, this is Tanya Klingelhofer.
And I need that spelling.
It's KLINGELHO, F as in Frank, ER.
Okay, thank you so much. Sorry.
Well, I think, you're correct. Reimbursement is the same, but certainly, it's not the intention for there to be an administrative burden. And I think maybe that's what Dr. Compton is concerned about. Otherwise we try to make it as simple as possible. We do this pretty much in most states that we're in with United Healthcare. So we've not had any concerns, but if there's any examples you want to give where you don't feel that is that there is parity there, then we'll be happy to take that back and look at it. But
So what I heard here is if the OMDs are doing routine vision, it goes to March.
correct.
If they're doing medical, it goes to the MCO.
That's correct.
Our routine goes to March, but our medical goes to March also.
For an OD, yes,
Okay, yes, us, yeah,
correct.
okay,
That is correct.
all right. It's not an administrative burden. It's just making sure we have parity and equity and.
Yeah.
And it is, I mean, even if the fees are the
Right.
same, we're being treated differently, and that always is a sticking point with some of us older guys. But anyway, we'll move on. That's the way it is for now, and we'll come back to that one of these days if we need to.
Okay. And I wasn't clear on the co-management of cataract surgery, what the discussion needed to be there, or?
According to our one of the surgeons we use, March, or who's the MCO for March? United Healthcare.
United, yeah.
It doesn't co-manage cataract surgery.
I'm not sure if someone from United can speak to that,
That's
or
what his office was told by someone from United. Of course, we have to bill it to March, and there may be a disconnect there, that they're billing their medical to United, and we're billing to March.
So March, so this is Scott Edmonds again. So March does pay the normal percent, that does it right with the 55 modifier. Again, as I said earlier, it's our desire to do this all under one shop. The plan won't let go of the medical part. So we can't control whether or not the physician has used the correct modifier and whether United processes it with the reduction that goes to the March. But given that there's segregated buckets, we pay the 55 modifier irrespective of whether the plan did it right.
Okay, I assure you, we co-manage with this surgeon all the time. They're billing it properly.
I'm not sure whether, I can't speak to whether what they're doing, that's invisible to us, but I do know that if you bill it for post-operative care with the 55 modifier, we're paying it irrespective of what the ophthalmologist or the plan did.
Yeah.
Okay. And we have billed that, so we'll.
Yes, so we might end up paying 120%.
We haven't been paid yet.
By in error, but we're doing the March piece. That's how we do that without input from what the ophthalmologist and the plan did.
Right, and just to clarify for the notes, March administers the services for United Healthcare and Molina.
Okay, this was United Healthcare though. This was United Healthcare. Yeah. So we'll see. We have billed it. We'll see if we get paid.
Okay.
See if he gets paid. Go from there. This just came up this week or last week.
Okay.
Matt, I think that's all I had here.
Okay, well, the next one is mine. We've had a few denials on medical refraction for cataract and diabetic follow-up patients, saying that they're only allowed one refraction a year. And I just wanted to see if that was truly the case, because there's many instances that you got to check status of vision more than once.
And this is Anna at March Vision. And are you submitting the claims? And this might be, too detailed, and we'll need to get some examples. But have the claims been submitted with that, medical diagnosis code?
Always.
Okay. I was just thinking if maybe that was what caused the concern. I think, Dr. Burchett, if we could ask you maybe to send us some examples and we can look at those for you, without without seeing some examples to see if there were other reasons for the denial, such as eligibility or something else. But we're, happy to look at that for you.
Okay, that still doesn't answer my question. How many refractions should you pay a year? Can I bill 2 if need be, 3 if there's the need for it?
Well, I'll let maybe Dr. Edmonds talk to the medical perspective, if you could do that.
Yeah, sure. So I think we've always considered the refraction to be a routine service because it's really hard to differentiate a refraction that's done for medical versus a refraction that's done for routine. So we only pay the 92015 once a year as whatever the annual benefit allows. So but the medical care, the 92s and 99s, any other visits you use are unlimited. So having worked in like a low vision environment or at Will's Hospital where my practice is, we often do refractions for anybody that are just like, I want to know what the best vision is. I'm not going to prescribe glasses, but I got to refract them to do that. And it's never been billable as a separate procedure. However, like for instance, on the new 99 codes, which are time driven, the fact that I might have taken 10 minutes to do the refraction that's not billable is going to add 10 minutes to my time. And it's going to be a 99214 instead of a 99213 because I did the refraction that wasn't otherwise billable. So it kind of comes out in the wash. But I mean, so that, March has always identified that as part of the routine benefit. And so the medical part would be paid 92 or 99 codes, but the refraction per se breakout is only paid once a year. So that's always been our policy just because it kind of mirrors the other carriers. Again, doing low vision, we do a lot of what I consider medical refractions, but I've never been able to get paid for them.
Well, then you're going to start to have an awful lot of people not getting refractive service then, just going to say, because typically when we do a procedure, there's a purpose behind it, and it is a separate billable medical code. So I'm just throwing that out there. You might want to review your policy. I know several other of the MCOs and vision providers for those MCOs do pay more than one refraction when indicated for like diabetic or cataract patients that we have to see more than once.
Well, we can certainly take that. We have a peer review committee at March that we can bring that's who generates our policy. So we can, as frankly, haven't heard that question in many years. So I'll be happy to take that to the peer review committee and see what the current take is. Think times do change.
Well, and Matt, so the other MCOs look at that refraction code and look at what medical diagnosis is attached to it. And that's what we've been talked to in the past, but that's how you differentiate between a routine and a medical. And so that diagnosis code makes it crystal clear why you're doing a refraction for a medical purpose versus why you'd be doing a refraction for a vision or routine purpose.
Thank you, Carol.
And Dr. Burchett, this is Ann Ritchie again at March Vision. If you could send those examples to me, I'll be happy to share those with Dr. Edmonds for his review and discussion at that committee that he referenced.
Okay, I'll pass that along to my billing staff so we can see if we can gather those up.
Okay.
So the next one is also mine, and I think my billing manager told me that a representative from March is coming to my office maybe next week. I can't remember the date off the top of my head to help work through some problems that we've had, but we've not had great help when we call in to March. And that's the next thing about finding out or solving our problems. They always say, well, we'll put a ticket in and we don't ever hear back. Or they'll say, well, just reference your LCD to determine if the procedure that you're going to do is a covered procedure or not for whatever diagnosis we're trying to do the procedure for. And we do that, but we still get denials. So we call and they say, well, we'll put a ticket in, and we still never hear back. So we've had all kinds of problems with that. And I just didn't know if that was just my office or if there's other people having that same issue.
So I can speak to that again. It's Scott. So the peer review committee, we don't use LCD since we have national policies on diagnosis driven payments. So our committee takes a look at the LCD is local. There's an NCD, which is the national code determination. So we use that as our base. And then, the peer committee, which is mostly all optometrists, actually. There's only one ophthalmologist on that committee. But we take a look at the NCD as our reference, and then we do there is some local guidance. So that's subject to change based on, obviously things change clinically over time. But if there is a diagnosis matchup between a procedure and a code that you feel is not being paid appropriately and should be, because times have changed, again, we'll take that back to the peer committee, and the docs will review it again and change. The policies are not written in stone.
Sure. Well, a couple questions to you on that then. First, if you're using the NCD, not the LCD, it would be great if the people that we talk to would tell us that. Second, it would be also great if after the review, we would hear back why it was denied. And then third, do you actually have a Kentucky licensed OD on your peer review committee?
Dr. Burchett, could I just interrupt for a moment? This is Ann Ritchie again at March Vision. And I heard you say, I think at the beginning, that somebody from March was coming out to your office. And I don't think that we have started that yet. Still due to some of the COVID-19 concerns. I don't know that any of our representatives have started to travel. So I just wanted to make sure that this was in reference to March.
All that I'm talking about is in reference, and I could have sworn that my billing manager, who I'll say rarely gets things wrong, said that March was coming to speak to her about, and it may be a phone call, I could be mistaken.
Oh, okay. Could be a phone call. Okay.
Yes, but she said that somebody from March was getting with her next week, if I'm not mistaken. I assumed that it was coming to the office.
Okay, that makes sense then. Probably a phone call. Like I said, I just wanted to clarify that we're not yet traveling due to some of that the concerns still surrounding COVID. Okay, thank you.
Yes.
So in answer to your other question, we do not have a Kentucky representative on peer, but I am like personal friends with David Jaco, so he is my go-to Kentucky question person. So I call him periodically about how, make sure that so he's not officially on peer, but he and I are old friends and from AOA, and I go to him with my Kentucky questions.
Sure, and that's wonderful, but by law, you're supposed to have somebody on your peer review from Kentucky. Because by law, Kentucky ODs are the only people that can deny our claims after they've reviewed them.
And this is Ann Ritchie again from March. So we are familiar with that. And, the claims that we deny will be for administrative reasons. So as an example, the member is not eligible, or perhaps the member has primary insurance. So, certainly, as you all know, the primary insurer needs to be billed and paid first. Medicaid is always the payer of last resort. So it could be that we're asking you, to bill that primary insurer, and the claim is being denied for that reason. But the denials will all be administrative in reason. And
I don't see that as the case for a lot of ours, but that's okay.
So Dr. Burchett, if you could send me those examples as well, we'd be happy to research that and get you specifics on those.
Okay.
And sorry, Dr. Edmonds, didn't mean to cut you off there. I just wanted to I thought that kind of fine line about our denials and that we were aware of the need for the Kentucky OD might be helpful.
So if you're aware of the, if you're
I-
aware of the need for it, but yet you don't have one, I'm a little confused by that because you know that that is part of the statute, yet you don't have one. So if we had a claim tomorrow that needed to be reviewed, you would not be able to be in compliance and have that reviewed by a Kentucky licensed optometrist to be approved or denied. So could you maybe speak to when you will have a Kentucky optometrist so you will be back in compliance?
Well, I'll have to connect on with some of the folks that aren't on the call regarding that. But it's our understanding that, you know, the claims for approval, the claims that are paid, there's no review that's required. You know, those are done based upon whether the member has the benefit and whether they're, you know, eligible. All right, and so that doesn't require any sort of clinical review. And then the same thing goes for the denial, that it's not any sort of clinical decision about the claim being denied. The claims are denied for administrative reasons. The member's not eligible. It was an invalid CPT code. There might be a primary insurer. And so those are all administrative reasons, and there's no clinical component to the, you know, to the review of that claim approval or denial. And that's why I asked Dr. Burchett to share some examples where it seems like some of those claims are getting denied, maybe that aren't administrative reasons, so we can do some review on those. But everything should be, again, you know, just based upon those administrative factors. So hopefully that helps.
I'm sorry, this is Lee Geis from Medicaid. I have a question for you, if you don't mind.
Mhm.
If are you saying that March will never deny an OD claim or an optometrist claim for clinical reasons?
Currently, right now, there's no reason for us to do that. Again, unless it's, you know, and I would have to defer to Dr. Edmonds for this, but if it was a, you know, a service that had a completely, you know, incorrect diagnosis code. But again, you know, we would consider that to be, you know, administrative, that the claim needs to be billed with the appropriate diagnosis codes for payment.
And so because your interpretation of administration includes a wide range of issues, I'm going to say that you must be also interpreting the statute to only apply to clinical determinations, correct?
Well, that is our understanding, is that the optometrist was needed when it was some sort of medical or clinical denial. Is that, did I get your question right there?
Yes, you did. You did.
Okay.
So you don't have one. That means you cannot deny anything except for administrative reasons. And what happens when someone disagrees with your interpretation of what's administrative?
Then we engage our health plan partners, which would be Molina or United Healthcare, for assistance there. And I don't recall that that's happened. But again, when we get those examples from Dr. Burchett, we'll do some additional review. And then, you know, Dr. Edmonds and I will also take that to discuss with, you know, some of our colleagues.
Yeah, just my understanding is that we're not delegated to do it. That's why we don't do pre-certs or any clinical reviews, because we have to be delegated by the plan. And so we don't have that authority. So that's why we don't have any of our clinical team. We would be happy from a clinical perspective to have a Kentucky optometrist on our peer review committee. That's not a problem at all. As I said, I lean on David quite a bit for any kind of question, but we have no authority to deny or approve clinical issues, you know, in Kentucky or in a number of states. So we don't utilize that. So our committees basically docks where we are, states where we do have a broader scope of privileges based on our delegation from the health plan.
Okay, so I just needed that. I just wanted to get that particular clarification, that you don't have authority to make clinical denials, that you would have to go back to the health plan.
That's my understanding. Is that correct, Ann?
Yeah, you are correct. And that's what I had mentioned, is that we would engage, our partners at Molina or United Healthcare as needed.
Okay, okay, thank you.
You're welcome. And like I said, once we get those examples, we'll be happy to share, obviously not any PHI information, but just, generally what we found about those. So we'll be happy to share that as well.
Sure. Well, the follow-up question I have then is, does Molina or United have a Kentucky OD to look at claims that have been denied?
And I think we'll probably have to take that one as an action item. I'm not sure that we've got the right representation from the health plans on the phone. So I think we'll be happy to take that and, work back with them.
This is Angie Parker with Medicaid. I will check on that, Dr. Burgett.
Thank you. I've got a question, Angie, to follow up. If we have a complaint on a denial because it's not been looked over by the Kentucky OD like we're supposed to be, where can we send those to the department?
We do have a process that you can send a complaint. I can get that link in the chat and put that in the chat for you.
Appreciate you.
Mm-hmm.
And the last item we have for March is, we've heard whisperings of frame kits coming out maybe next year, which is coming close on us. So is there any update for that, or we're still up in the air?
Yeah, hi, this is Adrienne Ferrer at March. Yeah, I mean, it's our standard model. We'd love to be able to roll one out in Kentucky, but it's, given that we're already live and everything seems to be going smoothly, it's not necessarily a priority unless are people anxious for a frame kit, or I'm not sure. Is it something we should prioritize? We love our frame kit model. It gives, over 1,000 SKUs available to the members through our contracted lab. But yeah, it really hasn't been a priority because, again, things are running smoothly and,
Sure. That's fine. We just wanted to check back in because we know it's been mentioned before, and just kind of look into the next year. So.
Okay. All right. Thank you.
Yep. Thank you. Well, thank you all for that discussion. Moving on, let's Steve,
I've got one more for for March Vision, if you don't mind. So I went ahead and I looked up the Kentucky Revised Statute for what Dr. Compton was discussing, 304.17A-173, reimbursement for services within scope of practice of optometrists, terms and conditions. Section 2, an insurer shall not require an optometrist to meet terms and conditions that are not required of a physician or osteopath as a condition for participation in its provider network for the provisions of services that are within the scope of practice of an optometrist. So I believe that definitely, from March Vision and United Healthcare, they need to definitely look into the law because that would be the part that Dr. Compton was referring to. It has nothing to do with the actual amount that's being paid. It has to do with the way that it is split between United Healthcare and March Vision. So that is just in support of what Dr. Compton said. That's our KRS, just for your reference.
Thank you.
Thank you, Carolyn. Well, Steve, I'm going to give it back to you for the next group because I think these were yours as well.
They are, and this was discussed at the last TAC as well, and they were going to research this. IQuest's policy on second pair of glasses is if they do not, if I'm understanding right, they will not pay for the second pair until 60 days have elapsed, and then they don't pay a dispensing fee for the second pair. I personally have a hard time. Some of these kids, say they're a -3 and they break their glasses and they got to wait 2 months to get another pair. And we do all the stuff to get the second pair, but we don't get paid a nickel for our efforts. And I just think that needs to be revised, and it may have been by now. I think IQuest and Anthem were going to take that under advisement after the last meeting. I just need to know where we stand.
Hi, absolutely. And this is Christy Medina from iQuest. Dr. Davis is on, but is having some audio challenges. So I figured I would go ahead and provide the update on his behalf. As you noted, we did say, that we would go back and revisit the policy, and we have done that, and we've discussed and we've decided to rescind the rule and no longer, bundle that replacement eyewear and dispensing fee with the initial payment for dispensing within 60 days. So, going forward, we'll pay those out as a regular replacement.
All right, sounds like the problem solved. Thank you.
No problem. Thank you. We appreciate that feedback.
Okay, well, thank you, Steve. Moving on, the next one is we're going to talk with the Visas a little bit on the 92 codes with the medical diagnosis and refractions. So if my memory serves right, I think last time, Dr. Levy, you said that there shouldn't be any problems with those, right?
Correct.
Okay. I have not had a one to pay yet.
Okay, so let me understand that, because the way it comes in, as we've been just discussing with our other folks on the phone, is that the 92015, based on the local coverage determination frequency and limit for medical services, should pay. So I need to see some examples where it's not paying for you, because I'm not having this across the board concern. And let me just confirm that with my team. Danny, are you on?
I am. Hello.
So I think you took a look at Dr. Burchett's examples, or we need some examples, but for what I'm seeing is we've been denying correctly. So Matt, I think it's something on how it's coming in or how it's being attached on your claim.
That's correct. So if I could just jump in real quick. The claims that we did pull on our end, and that's why we're probably asking for examples as well, because we're not finding any of those claims that are denying in that sense. We are looking at the claims that the 9.2s were billed with the refraction. The 9.2s have paid, but the refraction was billed with a refractive or routine diagnosis code and not a medical off of the approved list. So those are denying correctly. If you have some specific examples of billing that refraction with the medical diagnosis code that are denying, please send those over to us, because we're not finding them.
Well, I'll tell you, there's a stack of papers on my lady's desk in my billing department where they denied billed correctly. Miranda, I think, is our rep who is supposed to be in our office on the 15th.
Okay.
To look at some of that and a couple other issues we've been having. So we'll have those, if that's okay, we'll have those there for her. So that way we don't have to send a lot of paperwork to you all.
No problem.
And see what we can work out. But I can tell you, there's been a lot of them denied that just have a medical code, cataract, diabetic, those kind of things. No routine on them. So
okay, that'll be great. Let her take a peek, because like I said, I'm not hearing this from anyone else in the network.
This is Steve Compton. So now you are hearing from somebody else.
All right, well, good.
I've got 3 here, but I'm going to double check and see if that refractive CPT was attached to refraction. I mean, to routine.
And make sure where it's pointed. You know what I mean? Listen, I'm no billing expert, but just make sure it's pointed correctly to the medical side, not the routine side.
Right, and make sure
we
that
have been paid for some too, so it's better than it was. So
so make sure that when you're looking at that, to have the pointer only point to that medical diagnosis, not to both routine and medical. That it's only towards the medical, and then it should go through fine.
Okay.
Well, we'll look at that. We'll have the examples there for Miranda and see if we can't get it figured out. But I can tell you that unless I've not looked at them correctly, they're all pointed to the medical. So.
Okay, good. Well, let's take a peek at it. We'll get it fixed.
Yep. Sounds good. appreciate your help there. The next one, Steve, I think maybe you had this deny. I'm not sure. It's the, I know we've had it a time or two, but the 66982 for co-management.
Yes, on a complicated cataract.
Right.
code.
Right.
This is billing EDS directly, I think. Turns out it's not on the list.
I'll say, I think it was one of the ones that we had asked to maybe have looked at to put on the fee schedule.
Yeah,
I'm
it
not
should
sure
be.
where that stands. Yeah.
Because the surgeon bills it, so we've got to bill it with a 55 modifier. And then and we appealed it and got a denial letter again. And code is not billable to be rendered or billed by your provider type of 77. Optometrist is misspelled, but that's okay.
This is not an Abesis thing, correct?
No, this is
I didn't think so.
EDS.
Okay.
Yeah, you're off the
All
hook.
All right. Thanks.
So I think it's just one of those things. It's a code that's not used much, but it's well within our scope. When we co-manage, it just needs to be added to the list. I don't know if the Board of Examiners gives that to EDS. I don't know how that works. Or
Well, if I'm
DMS,
not,
whatever.
I could be mistaken, but before Dr. Poplinski came off the Board of Examiners, I had a talk with him because that's ours. We'd had that problem long ago. And he looked at it, and I think they put it on our approved codes list for optometry. So I don't know where the next step to make sure that we get it on the codes list for the department for EDS.
I don't know how that works. If they just adopt it, or it has to go through a regulatory process, or what. But anyway, it should be on the list. We don't use it often, but it's there. So I don't know who needs to
This is
take that.
Sarah with the Kentucky Optometric Association. Maybe Lee or Angie, is there a new Charles that's within the department now that we could send the code to?
I'm sorry, did you ask if there was a new Charles?
Yes.
There will never be a new Charles.
No, there will never
However.
be a new one, but maybe someone that's in his position at this time, possibly.
Yes, we have a new assistant director. His name is Justin Derringer. I will put his email in the chat for you, and you may send your questions directly to him.
Thank you.
Okay, I'm going to confirm his email address before I put it in the chat, so it'll be just a second.
Is that all you had on it, Steve?
Sorry, yes. Just
Okay.
one of those administrative things that probably should be added. Problem solved.
Sure. And then the next item was something that we talked about numerous times, and I think you said that they had a discussion at the MAC on it. So if you would, could you fill us in?
Actually, the KMA made a recommendation to the MAC for Medicaid to include medically necessary contact lenses. This was from the KMA's rep, but she's also a pediatric ophthalmologist. So I told her afterwards, I said, I'll bring it up at the next TAC because it's my understanding they are covered or are supposed to be covered. Now we get various denials for different reasons, but I think they're already covered. That recommendation the KMA made may be a moot point. I don't know. But I told Dr. Gupta I'd bring it up.
So Steve, Dr. Compton, you're right. It is covered under Medicaid. It's on our fee schedule. We pay it out.
Adults, do you pay it out for adults?
Yeah, for children and adults. Danny, am I correct? The fitting code is the 9207172?
Yeah, those are the fitting codes, but the medically necessary contacts are covered for under 21.
Under 21.
And 21 and over, it depends on the health plan, but yeah, the electives are covered under certain health plans for adults, but medically necessary is children.
Right.
Is it just the fitting or materials covered as well?
Materials as well. I think there's 10 10 different V codes
Yep.
that are covered, if I'm not
Right,
mistaken.
Under 21 is EPSDT, so if it's medically necessary, it should all be covered. There should be no question about fitting and or materials. But I think Dr. Gupta's recommendation was for adults, because once somebody turns 21, it doesn't mean that they don't need the lenses anymore. It just means that Medicaid has not assured coverage.
We would agree with that. We'll follow your lead on that.
The
let us know.
response to Dr. Gupta is that we are reviewing her recommendation now. We haven't finished with that.
So I did what I said I would do, and you're doing what you do, and we'll talk about it at the next MAC.
So then, Steve, at this time, I don't think if they're reviewing it, that it would make a difference if we sent the same recommendation for adults. I don't think that matters, because if they're reviewing it already, it won't.
Right.
Right.
Yeah, I wasn't proposing a recommendation. I just clarification, I suppose, is a better word.
Sounds good. Well, is it clear now?
Yeah, actually clearer than it was. Yes.
Okay. Well, the last couple items, the last big item is the discussion we've had several times with optometry being a part of KHI, and it showing up that we have to be on there in some of the MCO contracts. And I think, was it Avisus that had that in theirs? I can't remember off the top of my head, but I think that's the one.
Yeah, Matt, we were following, and Dale or Danny, keep me correct here, that the minimum is that we need to collect emails.
So the minimum requirement is for any newly contracted provider that you at least have to register for secure messaging on the KHI website. Eventually, we expect that will roll out to every provider is at least required to, or requested to. I don't think the language says actually required. I don't have it in front of me. To at least register for secure messaging on KHI. So the request and requirement that we have is just simply that you follow the request of DMS to register on the KHI website for secure messaging. That's it.
Okay.
This is Sarah with the KOA again. So when you're requesting this, it's only for the newly contracted ODs. So if there was an optometrist out there that received a request that had already been contracted with you all, is that correct? Well, I mean, should he have received that or no?
So yes, so our goal is to get everyone registered. Eventually the requirement will be there, and there will be a report out responsible or report out requirement for that, Sarah.
Okay.
The requirement, I mean, there is nothing that's going to happen to your contractor status, anything like that if you don't, because the language is the contractor shall encourage. I pulled it up just now. So we encourage all providers to register within 1 month of contract signing. And so the language and the anticipation is that eventually this will be across the board, at least the secure messaging. And so we're trying to get our providers to move towards at least registering for secure messaging.
Okay. Are iQuest and Mark's doing this as well at this point, or are you all just kind of waiting until it's required? And if you don't have an answer, you can email me at some point.
Hi, I'm sorry, it was Christina again. I'm just going to jump in due to some of the audios. So as far as iClass is concerned, yes, we are encouraging all providers. It's not completely required as of yet, but we have a pretty good success rate given that, you know, for the most part, providers prefer like the portals and so forth. So that is definitely part of our enrollment process as far as encouraging them in alignment with the requirement.
Okay.
This is Angie with Medicaid. Just to make sure that everybody understands, it is not a requirement. The MCO contract does say encourage. That was recently changed, but DMS also does encourage all of our providers to register as well.
Angie, is there wording out there that that Medicaid possibly has sent out? I don't know, sometimes I know you all send stuff to the associations to like tell people about this or explain it a little bit more, and if there's not, it's fine. I just was wondering if the department had any like more information we could send out to our members on that possibly.
At this time, I'm not sure that is something I can just state that the MCO contract, at one point, it did say shall contract with, but that has changed to encourage.
Okay, thank you.
Mm-hmm.
Okay, well, I think that clears that up then. Anybody have anything else? Any other thoughts?
Are there any updates on MCO, any changes going into next year we need to know about?
Good question. Adult vision benefits, other things.
I would just say steward on with WellCare, and we're continuing the same benefit we have for contact lenses and eyeglasses, the same as we have for 2021. We're doing it for 2022. No change.
And this is Jean with Anthem. And just like what Stuart said, we're continuing the value-added benefit as we had for the last year with the glasses and the contact lens.
This is Sarah again with KOA. I want to say the one MCO that was not offering adult glasses in 2021 is now offering glasses. And I believe, was it United? I may be wrong. You all are on here, but I want to say the new paperwork that was sent out from the department actually had all of the MCOs offering an adult benefit, glasses benefit for 2022. When last year there was only 5.
Okay, well, no body disputes that, then I guess that will be what we'll work with. TAC members, next year's meeting. What's your all's status? Do you want to try to have some in person if we can, or do you prefer to stay virtual? Half and half? Do we need to add meetings, or 1 a quarter been enough? How do y'all feel about it?
I think that one, like 4 a year, 1 per quarter has been good. I think virtual is really convenient. So that's my vote.
I agree, virtual is convenient. In person, I think it's a little more effective, but I don't know if it's safe yet or not. Some of the TACs are just following the lead of the MAC. When the MAC goes back to in person, they'll do the same. So I'd like to get back to in person at some point, but not too soon.
I'm flexible, but the virtual is obviously easier on me because of distance.
Right. Well, how about we keep it virtual for now, and if the MAC decides to go back, then we'll revisit going back live. How's that sound?
That works.
Or maybe even go live with the possibility to remote in. If that is even possible, I'm not sure. Anyway, so 1 a quarter, is that what we want to do? Does that sound good to you, Gary?
That's good.
And that's what we'll go with. We'll put together some dates and send out to see how that works with everybody's schedule. I know it's hard to look 6 months, a year out at this point. We'll try to come up with some dates and see how that goes.
Sounds good.
Okay.
Good to me.
Well, that's all I've got to thank everyone for jumping on here today, and we'll see everyone, I guess, next year on the TAC call here, and I would entertain a motion to adjourn.
I make the motion, we adjourn.
Second.
Thank you.
Thank you all.
Have a good holiday.
Thank you
You
all.
all too.
You too.
Bye-bye.